Hello and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, Educational Programs Coordinator for MS Focus, and I'm joined by Dr. Aaron Boster, who will be with us for the next hour answering as many questions of yours that he can. Now I'm delighted to introduce our speaker. So Dr. Aaron Boster is a board-certified neurologist specializing in multiple sclerosis and related CNS inflammatory disorders. He decided to become an MS doctor at age 12 as he watched his uncle, Mark, suffer from the disease in an era before treatment was available. Dr. Boster, who grew up in Columbus, Ohio, has been intimately involved in the care of people impacted by multiple sclerosis. He's been a principal investigator in numerous clinical trials, trained multiple MS doctors and nurse practitioners, and has been published extensively in medical journals. He lectures to both patients and providers worldwide with a mission to educate, energize, and empower people impacted by MS. He lives in Columbus, Ohio with his wife, Chrissy, son, Maxwell, and daughter, Betty May. Thank you, Dr. Boster. We're thrilled to have you join us today for this Q&A session. Let me just give everybody, before we start, a little reminder, if they haven't been here also, as to how we work the webinars. So what you can do if you have questions and comments is that you use the Q&A button in the app. That also allows you to send your question anonymously if you choose to. You can always ask your question live by raising your hand. And to do so, you click the raise hand button or press the *9. If you're on the phone, that's how you would do it with the *9. In either case, I'll call on you, at which time you'll unmute to ask your question. So now I'm going to turn it over to you. Let's see how many people. Wow, we already have 16 questions.
Oh, that's fantastic.
19 questions. Holy moly. Okay, let's see.
Thank you, everyone, for joining us tonight. As always, it's an honor to be here. Deb, thank you so much for having me back. You know, the MS Foundation is an awesome organization, as evidenced by your commitment to helping up people's games. And I'm really excited to answer some questions tonight. So let's see what we've got set up for us.
Thank you. And let me just say, I can say this at the end, or I could say it now while we have everybody's captive audience attention. You're going to be doing this every other month.
Yes, I'm really excited. We're going to have a really awesome year and really kind of help bring some things to light. It's going to be fun.
Good. Okay. So now everybody's saying hello, 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 hello. Okay. Let's see. Oh gosh, you rock, Dr. B. People are very excited.
I have to pay them to say that. It becomes very expensive over time. I think there's a question from Louis. You see, there's a question there from Louis.
Yes. Can I submit my question for Q&A already? Yes, you can. What are your thoughts on the Evishield antibody vaccine? I'll be taking it soon and I'm ready. Let's see.
I'm really excited about taking it.
Thank you. Mine is moving. So
no, I understand. So first of all, hey, Louis, it's nice to meet you virtually. And thank you for the really appropriate and contemporary question. So Evishield is a medicine that's only recently been invented to help combat COVID-19. And, you know, words are really important. And so just to be very clear, it's not a vaccine. So Evishield is not a vaccine. It's not priming your immune system to be better at fighting COVID, which is what a vaccine does. Evishield is actually 2 monoclonal antibodies. So those are like smart bombs that are injected into your body. And for the subsequent next 6 months, the drugs float around your body. And if they come in contact with COVID, they whoop the crap out of it. So to me, imagine you hire 2 giant gorillas to walk behind you, and they don't do anything unless somebody messes with you. And then the gorillas jump in and beat them up. And so Evishield is a really exciting option, but it's only available to people who are immunosuppressed. Now, as you're well aware, people with MS are not immunosuppressed, but many of the medicines that we give people with MS can make them immunosuppressed. And as a result, they're eligible to take Evishield. I've given Evishield to many of my patients. It's a fantastic product. I'm really glad it's around. And I think that it can help make things a lot safer. And so I'm excited that you're going to take it.
We have an anonymous question. Are we close to finding a treatment They probably mean a cure because it says, are we close to finding treatment for MS? I'm sure that's,
Yeah.
they meant to say
So,
cure.
so that's a very commonly asked question with good reason. I one time heard like a classic millennial meme, MS, where there's 27 treatments and no cure, right? Which is unfortunately true. Now, it's my belief, Deb, that we're not going to cure MS in my lifetime. And I'm not saying that to you to be a Debbie Downer or a Deborah Downer, and I'm not saying it, to be negative, but the reason I'm saying that is our understanding of the immune system is nascent. It's really kind of like not very developed. We're still learning about the immune system. I'll give you an example. Half of the immune system we've never been able to manipulate. The innate immune response, we're just now developing drugs that can touch it. We've never even been able to reach it. And so because our understanding of the immune system isn't fully fleshed out, I think it's a stretch to think that we're going to fix the disease before we clarify that. But I do want to share with you that in 2022, as we talk right now, we can do something which I'm very proud of, which is to make MS really boring. So if you think about other autoimmune conditions, the disease diabetes, which is an autoimmune condition, used to kill people. So diabetes used to be a death sentence because over 30 years, you lose your kidneys and die. Nowadays, you don't even know that your girlfriend has diabetes unless you order chocolate cake after dinner. And she fishes through her purse and pulls out her pen and gives herself an injection. Say, honey, what are you doing? Oh, that's my insulin. Now, I'm not trying to suggest for a second that it's easy to have an autoimmune disease. It's not easy to have diabetes. I'm not trying to suggest that. But if you play your cards right and work really hard, you can have a normal life expectancy and a normal life quality with diabetes. You can make diabetes kind of boring. And today, we can do that with MS sometimes, not all the time, but oftentimes. And increasingly, we're able to do that. Now, we are working towards a cure. We have clarified some really exciting things about EBV, mononucleosis, which is one of the key elements required to cause MS. And there's some exciting groundswell surrounding that. But I would rather focus our attention on living our best lives today in not allowing MS to make decisions for us, making MS boring, which is something that is viable and that we do in clinic all day or day.
Thank you. So someone said, I was diagnosed in April with MS, and apparently they found a lesion on their spinal cord. They took Solomedrol, and until now, that's what they've taken. I still feel stinging in my neck and numbness that comes and goes, especially when I rest my back. Is that MS related? I use Aubagio.
So that's a very good question. And if we take one step back, humans are born without instruction manuals. Right? We don't have a book to look up, like, if you have these symptoms, then this is messed up. Like, that doesn't exist. And as we live our lives, we're trying to sort out our symptoms. And that's actually kind of hard to do. Now, here we have a situation where someone had an attack, and by description, they had a transverse myelitis, where the spinal cord becomes inflamed, and then stuff below the spinal cord doesn't work very well. And it sounds like, based on the question, that there was some neuropathic pain. This person was treated with steroids, which quelled the inflammation, but it left residual deficit. So it doesn't sound like they fully recovered. Maybe they got, like, let's say 80% better. There's some residual deficit. Now, I have two comments about that. Comment number one is, it's too early for us to think that you're stuck with that. I would submit to you that what you're left with at a year is probably what you're going to be stuck with as a residual deficit. So it's too early to say that. You have to keep in mind, please, that steroids work for the lifetime of the white blood cells they affect. So it's about 3-4 months. So the benefits of the Solomedrol will continue for several months. The second thing I want to say is if you're left with a residual deficit, that sucks. And I want you to use it as a reminder of why you take Aubagio. You don't take Aubagio to get rid of what already happened, because you can't rewind time. You take Aubagio to prevent a future relapse. And if you need a reminder of why you're bothering taking Aubagio, it's the back pain as a reminder of why you don't want something else to happen. Now, I'm going to keep my fingers crossed because I think it's really early and you still may make a very meaningful recovery.
Thank you. So Dawn says, I'm a new MS warrior. I have foot drop, gait issues, and walk with a cane. I tested L300 Go, and it worked great. Looking for counsel in this device and any charities, foundations that may help support as it or the walk aid not covered by
Yep.
insurance.
Yes.
So
So what this person's talking about is really cutting edge technology. And let's just unpack this question a little bit. So when you talk about a foot drop, and I'm going to pretend that my arm is a foot. Okay. So if this is my leg and this is my foot, right? My hand's my foot. What can happen is it'll flop. And so when you're trying to, when you're trying to move on the ground, it keeps dragging on the ground and your toes can get caught and you can fall. Right. So a foot drop is a really frustrating symptom that really jacks with your ability to ambulate. And one way to combat foot drop is through physical therapy to try to strengthen it. Another common way to address foot drop is to use a piece of custom-made plastic or lightweight metal shaped to your ankle called an AFO, or ankle foot orthosis, right? And it's basically a piece of plastic in an L shape that cocks your foot up so that you can clear the ground. And that allows you to clear the ground so the turf monster doesn't grab your foot and make you fall. What you're talking about here, these are electrical devices that are next generation. And what they do is they cause the muscle in the front of your leg to fire and kick your foot up. So it forces your foot up, and it's set up on your legs so that it's timed properly with your gait. So when your legs cross each other at a delay, it cocks your foot up. And it allows you to recreate normal gait mechanics, which is freaking awesome. That's really cool, but they're super expensive. And I'm talking like over $5,000. And so, I practice MS in Central Ohio, and at least in Ohio, money doesn't grow on trees like that. And most patients cannot afford that. And so I understand why this person's asking about foundations. I'm not aware of any foundation who currently helps fund those. Now, that doesn't mean that you can't reach out to a foundation and ask if you could submit a grant. I have had patients who are really creative set up a GoFundMe. Like literally, they set up a GoFundMe account and they fundraised and they were able to raise enough money to get a Bioness. And so I do think that there's really cool applications of these devices. And one of the things that's really neat is any company that has them, they'll let you borrow it a little bit, like either in the store or to take it home for a day, so you can kind of see what it's like. I wish there was mechanisms to make them more affordable, but at present, you touch on a really important issue, which is it's cool tech that's really hard to pay for.
Yeah, thank you. And by the way, the Multiple Sclerosis Foundation has helped people with Bioness.
That's awesome.
Unfortunately, it's so expensive, and we can't afford to pay very much of it. So the individual would have to find other foundations
Funding
also try to get that together, including possibly even some of it coming from themselves. But we have helped people with that. So
I just want to that's so important. Repeat it, please.
Yeah. So the Multiple Sclerosis Foundation has been known to help people purchase their Bioness, but it's a fraction that we're able to help with compared to the huge expense of the item itself. So what we generally try to do is get other places, we encourage the person who needs it to go out to other foundations and see if they can get additional help. We try to see if they have other funding personally that they can add to it. So, but that's something that they can call us, or they can go online and look and actually ask us to see if we can work with them on it. So, yeah.
I think it's amazing that you guys do that. Thank you. I want to share just one really quick story. A patient of mine who has done very well for himself, and he was able to afford a Bioness, and he did something beautiful. He bought one for a young lady that couldn't afford it. And that just makes me almost tearful. And he'll never tell anyone that. He told me that privately. But there are some people in this world that are absolutely angels. And that's an example.
I agree. There are some angels, and they won't tell you they're angels. You have to figure it out yourself.
Yeah, they look like people, but they're not.
They are. So Terry says copaxone super, actually, copaxone super responders, ? I've been on copaxone since 2000 and have responded really well. right now, this person's 74 years old and doing really well. And since they were diagnosed since 1978, they're doing better now than they were in 78.
Wow.
They are on copaxone since 2000. Should they consider changing therapies?
No. So that's a great question, and thank you for asking it. And the term is actually appropriate, copaxone super responder. Another term that you'll hear now is legacy patient. And if I may, back in the ancient days of yesteryear, when what we had were the first line injections, we used them. And subsequent to that, there are other newer medicines that have come out. And some of those newer medicines are clearly superior to the older medicines when you compare groups of people. But the person who asked the question is not a groups of people. That's one human being. And it's true that many people fare better when they escalate to other medicines, but there are some people like this person who asked the question, and they are a super responder and they're crushing it on copaxone. And if that's the case, that's really awesome because copaxone is profoundly safe. It's without question the safest of all the MS disease modifying therapies. It's a medicine that we can use in MS and HIV, MS and cancer, MS and pregnancy. It's a really safe medicine. And so if you're a super responder to a super safe medicine, I'm in heaven. I think that's fantastic. Now, my one caveat is it's not easy to call yourself a super responder. So this person certainly sounds like they're doing really well. But when we talk about someone who's doing really well, I mean, no attacks, no new spots on MRI, no change on exam, no change in neurocog testing, no accelerated progression of brain volume loss. I mean, so the bar needs to be set very high so that we don't let disease activity sneak by. But that's fantastic. I'm really glad to hear that. And I wouldn't touch your drug. I would just give you a hug. That's awesome.
And I like the word super responder because my son-in-law is a paramedic firefighter and I call him my super responder.
There you go. There you go. And he is.
And he is. And Cassandra Cassandra's asking, can you please give me info about NMO and MS? Most of the time I read that you have one or the other. However, due to the number and the location of lesions, doctors have told me I have both.
So you do not have both. I don't know you. I haven't looked at your scans, but I don't think that's possible because the pathophysiology of NMO and MS are actually very different. Like the underlying pathology that causes the damage is not the same pathology. But clinically, they're kind of similar diseases and they can be really confusing at times. So let's just talk about it very briefly. So MS is an autoimmune disease where your immune system's inappropriately attacking you. And so is NMO. They're both autoimmune diseases where they're inappropriately attacking you. In MS, the attack occurs anywhere in the central compartment. So the entire brain, the optic nerves, the spinal cord. That's a lot of real estate. NMO affects less structures. It affects the spinal cord, the stem of the brain, and the optic nerves, and to a much, much, much lesser extent affects the brain itself. And so typically with NMO, what we see is recurrent episodes of optic neuritis, recurrent episodes of transverse myelitis, and then there's a couple other types of attacks that you can have. And in between attacks, people with NMO don't have progression. Now, people with NMO tend not to have oligoclonal bands or OCBs on their spinal fluid, and a good percentage, over 70%, test positive for certain antibodies that test for NMO. There's another antibody that tests for a cousin of NMO called MOG. And the treatments for MS and NMO have some overlap, but they're not all the same. In fact, certain MS treatments make NMO worse. So giving someone with NMO interferon beta products like beta-seron or Rebif or Plegridy or those kind of medicines are really actually bad news bears for people with NMO. NMO is a disease that's driven by the humoral immune response, the B cells. And so B cell depleters like rituximab, ocrelizumab, ufatumumab, these medicines, which are MS medicines, would also treat NMO effectively. Now, what's really exciting to me is that within the last year, there's been several new NMO medicines specific for NMO and approved for NMO. And so for the first time ever, we actually have choices in what medicines we use to treat this nasty, nasty disease. Now, there can be situations where a human being seems to be straddling both, and we just don't know yet. Like, we're not sure if it's going to evolve into NMO or evolve into MS. And in those instances, most of my colleagues and I reach for a B cell depleter. We put you on rituximab or ocrelizumab because that will treat both MS and NMO. And then later, when we figure out what it is, we know that we've got our bases covered. Thank you for asking that question.
And so let's see. Pat says, I've been diagnosed with MS for over 20 years. I moved to Florida from Georgia, see a VA doc who says I've aged out with none changing MRIs, says I don't need MS meds anymore. I was on Aubagio. However, since being taken off, I have return of MS symptoms to point I can hardly walk. Also a couple of new symptoms. What he keeps telling me is I don't have MS anymore. They just won't listen. What do I do?
So I have to remind myself that I'm on a national live stream, and it's important that I am polite, because I would like to not be polite in my response, but I'm going to be very polite, Deb. You need to find a new doctor. So you don't need him or her to tell you your life experience, because you're a you expert. And you know you're getting worse, like you told us on the question. Like, you can tell that you're not doing as well. So it doesn't matter if you attended med school, because you're an expert in your MS. You're an expert in your body. And it doesn't make any sense to me that you would have a chronic neurodegenerative condition called MS that could do exactly what's happening to you. Your doc took you off your medicine, and yet now you have a brand new condition which mimics MS perfectly. That doesn't make a lot of sense to me. Now, there's a study that I'll share with you, and it's actually, there's a couple studies that all teach us the same thing. And these were studies with people with relapsing MS that had had no disease activity for 5 years. So their MRIs were stable and they didn't have relapses, kind of like you're talking about. And they took them off their medicine and they watched them for about 2 years in this one study that I'm remembering. And they concluded that it's okay to do that because only 1/3 of the patients progressed in disability. Excuse me? So if you tell me that my mother was one of the 1/3, I will smack you, because I love my mother and I don't want her to have progression of disability. And I love your mother and I don't want her to have progression. And so I'm not okay with that. Like, that's not okay with me. And Aubagio is inexpensive. Aubagio is covered by the Veterans Administration Hospital, I happen to know. Aubagio is a safe medicine and it's easy to take. And it's really good at slowing disability progression. And it's really good at slowing brain volume loss. And those are things that are very important. And so, with as much fake respect as I can muster, I don't think that doctor's on point, and I would strongly encourage you to seek a second opinion. Now, the VA system will allow a dispensation to see a different doctor if you push them. If they have an MS specialist, if the person you're seeing is a so-called specialist, it's a little harder. But if they're a general neurologist, you can demand an MS neurologist, and the VA system will be forced to send you to a real MS doctor, whether that be within the VA system or outside of the VA system. So I, for example, I no longer work at a Veterans Administration hospital, but there are dispensations for probably about 6 or 7 of my patients that are allowed to come see me, and I'm allowed to treat them. I have other patients that are cared for within the VA system, but I see them and make recommendations that then the VA doctors typically execute on. So I want you to be selfish because it's your body, and I want you to be a self-advocate. And if he won't, or the doctor won't listen, go find a different one, please.
I like that answer.
I tried really hard to be polite, Deb. I hope I did okay.
You did a great job. They can't get you while you're on here. You can say whatever you want. Okay, so this is a really good question, and yet it's written in a way that I really don't understand how I'm supposed to say it. So maybe the two of us together.
Which one is it, so I can try to find it?
From Amy, and it says, I know as a PWMS, I am sensitive to extreme temperatures, but can experiencing extreme temperatures at night, very cold and then very hot, be associated with MS? But I don't know what the beginning is. And I don't want to
person with MS. PWMS is a internet abbreviation, person with MS.
Thank you.
So, and I didn't see the question, but I heard what you said. And so they're experiencing significant fluctuations in I'm really hot, I'm really cold, I'm really hot, I'm really cold.
At night.
So that is not a common MS symptom. And when I hear that, immediately I think about your endocrine system, like your thyroid, and I think about, if you happen to be a woman, perimenopause. Those are two situations where, because of hormonal changes, you can get really hot and really cold and really hot and really cold. And that can definitely happen. There are very rare situations where MS can interfere with your temperature gauge, but it doesn't present like that. It doesn't cause hot and cold back and forth at nighttime. So, you know, as my mentor used to say, sometimes nature is a little too generous, and you can have MS and a goofy thyroid, or you could have MS and go through menopause early, or something like this. And I would start by talking to the primary care doctor about those things so they can explore it further.
Thank you. Teresa wants to know, does copaxone and gabapentin contribute to bone loss, and that you know of?
No. Now, MS contributes to bone loss. So having multiple sclerosis, independent from being a boy or a girl, and independent from steroid use, causes accelerated bone loss after the age of 50. And so it's a best practice for people with MS over the age of 50 to have a bone density test every couple of years, because you can have bone density loss completely separate from any medicine that you're taking. And bone density loss is treatable. And so if you have bone density loss, I wouldn't stop my Neurontin or my copaxone, but I would definitely characterize how bad it is and start a medicine to beef it back up.
Thank you. Linda says she was diagnosed in 1996 after having symptoms for 17 years prior. Been through most of the DMTs and stopped after 3 hospitalizations for low WBC illness. Recently, I changed to a new neurologist, and she thinks she doesn't think I have MS. I also have had EBV twice, 5 years apart. Are there ways to mentally deal with this huge turnaround in my life? I still have all the symptoms and disabilities. So are there health care personnel to help a person like me to deal with this undiagnosis?
Yes. And that is a really, really good question. So thank you for asking that question. There's a couple papers out there that suggest that in large academic MS centers, the misdiagnosis rate is around 11%, which is very bothersome. And, you know, we don't have a test that's definitive for multiple sclerosis. Like, you don't draw blood and say, haha, MS. That doesn't happen. It's not that straightforward. And so it is possible that you could have a different condition, which is masquerading as MS, and it could be missed. And I don't think there's an MS neurologist on planet Earth that hasn't had that happen to him or her at least one time. And if you carry an MS diagnosis and you change doctors, they should be able to prove you have MS. So I tell my patients, I should be able to prove to you that you have MS, because MS is not a sensation or a thought or a feeling. It's a diagnosis which can be confirmed. And so sometimes we go through the rigor of repeating MRIs. We go dig up old MRIs. We do a lumbar puncture again. We may do visual evoked potentials. We may redo a workup to try to reconfirm the diagnosis. And I guess as I think about your comment, I have 2 things that I like to say. The first one is, if this one doctor doesn't think you have MS and the other doctor did, it might be appropriate to have a tiebreaker. And I wouldn't go to a tiebreaker just anywhere. I would go to a tiebreaker to a premier diagnostic center, right? I would go to a place where they do only MS and they do it at a very high level, because you don't need another general neurologist to go through the criteria. No, you want someone who thinks about MS all day long to lay eyes on you and help sort it out. And I think that's a reasonable request to get a tie-breaking opinion if there's question on the table. So that's my first comment. My second comment is to answer your question, which is, yes, there are people to help. And I want to talk about 2 kinds of people. The first kind are special psychologists. Now, I have a friend who's got cool hair. She's got crazy big, cool hair. Her name is Dr. Sullivan. And Amy Sullivan is an amazing PhD psychologist up at the Cleveland Clinic Mellon Center, which is in Northern Ohio. And she is, in my opinion, the most impressive MS psychologist on earth. She's trained multiple fellows, and they do God's work, and they help people grapple with symptoms and grapple with diagnosis and grapple with misdiagnosis. So that's where I'm going with this. So my first comment is finding a psychologist or another trained therapist to help you process those emotions is, in my mind, required. I mean, that's a real big twist of your thought process. And so I think that's a group of people that are super helpful. And you may ask them if they have expertise in a word that I'm about to teach you. The second group are functional medicine doctors. So when I'm going to date myself, and you'll realize that I'm an old fuddy-duddy, but when I went to med school, that didn't exist. There was no such thing as functional medicine. Like, that wasn't a discipline. And functional medicine has become a discipline, and it's intended to deal with things that are functionally related. So they're not caused by neurological damage. It's a functional problem, but it's still a problem. It still causes issues, and it's still treatable. And so functional medicine folks are pretty fantastic. And if you find yourself in this situation, I would try to find a talk therapist that has some expertise and or a functional medicine group who will invariably have a therapist within their organization, and they should be able to help you. Good question.
Thank you. By the way, can you just tell me again the name of the doctor, because I'm writing it down?
You mean my friend in Cleveland Clinic? Yeah, so that's Dr. Sullivan,
Okay.
Dr. Amy Sullivan. She's a PhD in psychology. The woman is a dynamo, phenomenal.
Okay.
Yeah, really cool lady.
Yep. Thank you. So Mary Lou said she gets horrible skin ulcers when she used the injectables. It was 3 different meds. What should she do?
Fortunately, in 2022, I almost said 2023, which is funny, but fortunately, in 2022, we have a lot of medicines that are pills and infusions. And so you're not required to inject anymore. In the era of the 90s, when all we had were shots, it was really stinky. And if that happened, we kind of had to beg you to please do it anyways, because we didn't have another way to give you medicine. But now, gosh, I can think of 2 different flavors of Aubagio. I can think of 3 different versions of Tecfidera. I can think of Mavenclad. I can think of Gilenya, and 3 Me Too drugs that are like, I can think of a bunch of pills that don't require you to self-inject. And there are some really highly effective medicines that are monoclonal antibodies, infusions in the vein. And so, excuse me. And so I don't think you have to inject anymore. Not at all. In fact, I would shake your hand and agree, no more self-injections.
Thank you. Thank you. Okay, so Maggie says she was diagnosed in April due to optic neuritis. Since then, she's had 2 attacks of diplopia.
Yep, double vision.
I've had symptoms since 2016, but mild. Why all of a sudden am I having multiple bad attacks? Is it stress from diagnosis, progression, or just a fluke?
The real answer is we don't know. That's the real answer. Infections in vaccines can trigger attacks sometimes. And so if you've had a bout of infections, that's something that we can see. The discussion of whether or not stress can trigger an attack is an ongoing debate amongst MS neurologists. I'm in the camp where I think it can, but I'm probably in the minority. And again, sometimes nature is just goofy, and you just have a run where there's some bad stuff going on. And what I would want to do is dig in, try to treat the attacks, treat the symptoms that are left over, and then upgrade your medicine onto something so hopefully we don't have attacks next year, and 2023 can be boring.
Thank you. Susan's asking, how often should spinal MRIs be ordered? Should they be done with and without contrast? She's had brain and cervical MRIs, but never spinal. I was diagnosed with RRMS in 1989.
I really like that question. Thank you. MS affects the brain and the spinal cord. And spinal cord involvement is more important than brain involvement as it relates to disability and problems stuff. And so having an MRI of your spine is really, really important. And it's my belief that a best practice when you're diagnosed is to get a really high field image of brain, cervical, and thoracic spine so that I know where we're starting from. And then after that, I like to repeat the brain every year, at least until you're 60. And I repeat the cervical spine typically every other year. Why do I do that? Well, the Consortium of MS Centers, of which I'm a member, suggests only repeating the spine if there are new neurological symptoms. And I get that, but I don't agree with that because I've seen plenty of times where I get an MRI and lo and behold, there's new spots on the spine and the person didn't know they had an attack. So I think that it's worthwhile to take a look. If you order a spine every year, the insurance will raise red flags. Okay. So if I get a spine every other year, I never seem to have a problem. And so that's my style. I don't repeat the thoracic spine routinely because the statistical likelihood of new stuff is less. I only get the thoracic spine if there are new symptoms attributable to the thoracic spine.
Thank you. And Allie has a question sort of related to what you're talking about. So we're going to go with that one first. If we know our neurologist uses an older MRI scanner, and this is his personal scanner, so this is where they have to go, are we hurting ourselves by not having the latest and missing out on what we should see? It worries her quite a bit.
Do me a favor and read the beginning of the question again. I want to make sure I heard it correctly.
Yeah. If we know that our neurologist is using an older MRI scanner and it happens to be their own personal scanner, this is where, you know, the patient is required to go. Are we hurting ourselves by not having the latest and possibly missing out on what they should see? It worries the patient. So
yeah, so I get that. I mean, that's an intersection of ethics, right? Like, and let's break that down. If the scanner is a 1.5 Tesla or higher strength magnet, I think it might be okay. If it's less than a 1.5 magnet, it should not be used in MS. If it's a 1.5 magnet and the protocol is gorgeous, so 1 millimeter cuts with no gap all the way through from stem to stern, you can protocol a 1.5 Tesla MRI so it has really good pictures and it's actually okay. But most community scanners are not set up like that. They're set up to be faster, like real quick, and the picture quality isn't as good. So it's my strong desire to image all of my patients on a 3 Tesla MRI. Now, I don't own an MRI machine, and if I did, I would probably want my patients to go there. But the question is could we miss something? And I just want to come back to one comment. I don't think it's fair that the patient is required. In fact, I don't think they're allowed to be required to go there. It might be strongly recommended by the practice, but it might verge on unethical or illegal to require the human, to not give them any choices. And so I would say, hey, doc, I understand that you like your scanner. Do me a favor. This year, let's go to a 3T down the street, just so I can feel comfortable that I'm not missing anything. And then I'll go back to use your scanner next year. And if they gave you a hard time, I might ask them a business question. What is the financial incentive for you to image me there? Now, I'm not saying that because I want you to get in a fight with your neurologist because she's allowed to own a scanner. I mean, I run an infusion center and that's a for-profit thing, but I do think it's a fair conversation to have. The punchline is, yes, you can have really good images on a 1.5 magnet, and it really depends on how good the protocol is. And I think it's a fair question to have with the neurologist because it's your brain that we're taking a picture of.
Thank you. Gina says, if Gilenia has kept her at bay for approximately 10 years, is there any new updated version of it?
Yeah, 3 new versions. So Gilenia is an S1, P1, P3 receptor. So it's got 3 receptor sites that it deals with. And Gilenia is the first generation of these S1 receptor modulators, but there's now Ponavoy, Zeposia, there's Mayzent, and those are 3 second generation Gilenias. They're Me Too drugs. And they are not more effective than Gilenia, but they have less side effects than Gilenia. Specifically, they don't have the same cardiovascular risks when you start the medicine, and you don't have to do the first dose monitoring. So yes, there are second generation medicines, and I don't think that they are superior to Gilenya from an efficacy standpoint, but they do have an easier startup, and I think they're easier to get off, which is a good idea. And they're still on brand, which means there's still copay assistance for patients who need copay assistance. Whereas Gilenya just lost its label, and so very soon that may be a major issue for folks if they need copay assistance with Gilenya.
Thank you. Deborah wants to know if you haven't had another attack since the first attack 1.5 years ago. However, you still have symptoms. Would you start treatment with Ocrevus?
Yeah, absolutely, I would. So the placebo rate of attack in a clinical trial, when you do a clinical trial with a placebo arm, people have an attack about once every 3 years. So if you had an attack and nothing's happened for 1.5 years, that does not suggest you're okay, not at all. And we don't take a birth control pill because we're trying to get rid of our kids. They're already born. You could take birth control the rest of your life and you'll still have 2 children. You take birth control because you don't want an unplanned child. So you don't want to wait until you have unprotected intercourse and then take birth control, because it won't help you. You have to take the birth control pill before you have sex, right? And in the same fashion, I don't want you to take Ocrevus when things are horrible and you're doing bad. I want you to take Ocrevus beforehand so that you have no idea what bad is. Yeah, I would absolutely do that, like yesterday.
Thank you. Connie wants you to talk, if you can, about extreme fatigue, because she said she's on Provigil, but still so tired.
So fatigue is the most common symptom in multiple sclerosis. It's also the leading cause of loss of work in multiple sclerosis. It's also arguably the least understood symptom in multiple sclerosis, particularly by people's families. In our culture, it's cool to be tired. Like, hey man, I'm really tired. Oh yeah, me too. But when someone with MS says they're tired, that's not what they mean, because MS fatigue is in its own category, in my opinion. And so the person that wrote the question asks about, she used the term, I think, severe fatigue. I oftentimes use I actually think about 3 different kinds of fatigue, but the kind she's talking about, I call pathologic fatigue. Both she and I are trying to use a word in front of the word fatigue to tell them, hey, this is not normal. I'm tired because I stayed up late to watch TV. And pathologic fatigue is a monster. And the best example that I've ever come up with in an attempt at helping a family, like a spouse, understand was the following analogy. So Monday, you get up, take a shower, eat your breakfast, go to work, come home from work, eat dinner, play with the kids. And when they go to bed, start watching my YouTube videos, right? I got about 530 of them. So I want you to get through at least half of them. Don't sleep. I want you to stay up all night long, take a shower in the morning, go to work Tuesday morning. All right. Work real hard, come home, eat dinner Tuesday night. When everyone goes to bed Tuesday night, stay up until you finish my videos. All right. So you're probably going to get about an hour of sleep that night. Now, on Wednesday morning, you and I are going to go for a walk and we're going to talk about fatigue. And that's about as close as I've come to trying to help someone understand, because it's the kind of fatigue where you're struggling to keep your eyes open, let alone trying to appear like you're listening. And it's devastating, and it causes people to lose their quality of life and to lose their job and a bunch of other stuff. Now, in fact, there's other kinds of fatigue in MS. There's a motor fatigue and cognitive fatigue, but we're going to stick with the pathologic fatigue for this question. And there are a host of things that we can do to combat it. So, Deb, give me a number like 2 through 10.
6.
6. Let's do 6 things that can combat pathologic fatigue. So I'm going to cheat, and we'll do 7 because the one that she already gave us. So I don't want to do that one. So there are medicines that can help trick the brain into being more awake. And so modafinil, the trade name is Provigil, and the newer version, armodafinil, trade name is Nuvigil, are central acting stimulants that are fantastic in MS. They trick your brain to be more awake, and they can really make a difference. Now, taking them takes a careful hand, because You have to dial in the timing of the dose and the dosing amount so that you're awake and thoughtful, thinking clearly during the day, but still able to sleep at night. And so oftentimes it takes several manipulations. We're going to take between 50 and 200 milligrams when you wake up. And we may take another 50 to 200 milligrams at noon to help you with the second half of your day. So that's one of 7. So the second one, just because we're talking about medicines, is a different kind of medicine, an amphetamine salt, like Adderall, Ritalin, those kind of medicines. And those are also central acting stimulants, and they're fantastic at helping MS fatigue. And they can make the difference between maintaining your job as a busy litigating lawyer and being voted off the island by the other partners. And that's actually a real situation that my patient faced. In a combination of Provigil and Adderall saved his job. So the medicines can be helpful. Now, number 3, we'll do a supplement. All right. So levocarnitine, L-carnitor, a gram twice a day, is been shown in clinical trials to help with MS fatigue. In fact, it beat out an old medicine, amantadine, that we used to try to use for fatigue. And so levocarnitine can be really, really helpful. Right. That's number 3. Number 4, water. You're gonna be like, what? But if you up your water game, your fatigue goes down. And if you don't believe me, try it. Give yourself 100 ounces of water a day for a week. And then you can write me a note and say, Aaron, you were right. I can't believe it. Thanks a lot. And you don't even have to say any of those words, but just know that it can help you, right? So upping your water game is number 4. Number 5 is to make completely and utterly certain that your sleep is fantastic. You need to budget 8 hours of sleep, not 5 or 4, but 8. And you need to make sure you're getting 8 quality hours of sleep. So if you have sleep apnea and you snore and your kids can hear it when they're sleeping at the neighbors, you got to treat that. If you have restless leg syndrome, you got to treat that. If you have a situation where you're getting to pee every hour and it's waking you up all night, you got to treat that. You have spasticity keeping you awake, you have to treat that. We need you to sleep like a rock star, because otherwise you're robbing yourself in the morning when you wake up. Number 5 or 6 or something like that, I think maybe number 6, we're going to talk about taking a power nap. Now, a power nap is an hour or less. All right. If you're sleeping longer than an hour, you're not napping, you're sleeping. But taking a power nap can be better than Provigil to recharge your battery and help you with energy. My last tip sounds paradoxical, but it's not. It's exercise. So even though it sounds crazy, you say, Aaron, you have no idea how tired I am. There's no way that I could do that. You might be shocked that if you can go for a walk after dinner, you sleep better and have more energy the next day. Because if you exercise, it builds your energy reserves. So there's 7 tips to help pathologic fatigue. Now, if you want to hear a bunch more, I have this YouTube channel. It's my name, Aaron Boster, MD. And I have a playlist on fatigue where I have no less than like 15 videos talking about tricks and tips to help with fatigue. So you can check those out.
I have, and they're good.
Thank you.
Do you want a second just to catch your breath? You're like
Nope.
the Energizer Bunny.
No, we're good. I've got my seltzer water here. I'm good to go.
Okay. So is treatment with stem cells effective, and should a patient consider it with or without DMT?
That's a really contemporary question. Deb, I love this MS community. I mean, if you take a sample of people impacted by MS, collectively, their fingers are literally on the pulse of the disease. It's awesome to interact with a group of people that are motivated and educated, and they desire to up their game and learn. And that feels good. So thank you, whoever asked that cool question. So stem cells sound sexy as hell. We're going to take these stem cells that can be anything they want, and we're going to inject them into your body, and then you're going to become beautiful and taller, and you'll speak more pretty, and all these great things will happen to you. And that's not the way stem cells work. And when you say stem cells, that's a cell in the body, like a bladder cell or like a liver cell. All right. So a stem cell doesn't know what it wants to do when it grows up yet, and it can become something else. And it sounds really lovely to take some stem cells and replace your bone marrow and cure your MS. And that's not how that works. Stem cell transplants are increasingly becoming studied in MS, and they're becoming safer and safer. So when we started to do stem cell transplants, they could cause death. And fortunately, we haven't seen a death in stem cell transplantation in a little while. It's a very serious procedure though. And it's not something that I would recommend be done outside of a clinical trial. So I do not recommend that you travel to an exotic location like India or Chicago and pay someone a bunch of money to swap out your bone marrow outside of the context of a clinical investigation because of the safety concerns that are involved. Now, in the future, like in 10 years, do I think stem cell transplantation will be FDA approved? Yes, I do. I do think it will be. But we have a lot of work to do before we get there. Now, there are charlatans, there are quacks who participate in something called stem cell tourism. And the American FDA is trying to crack down on this big time. But there's still these people out there, and some of them live in Ohio and have the audacity to try to treat my patients. And they'll do something where they'll take your fat and they'll go in the back room and they'll do something to it and they'll come back, and for a lot of money, they'll inject the stem cells back into you. And I really don't think you should do that. That's quackery. It's not going to help you. When you study a stem cell transplantation, the things that really help are not the stem cells. And let me explain this. Here's how a stem cell transplant works. Step one is we need to collect stem cells from something, either from your body, we call that autologous stem cell transplant, or from like cord blood or somewhere. So you got to have some stem cells and you put them on ice. That's step one. Step two is you murder the human. You give them lethal doses of chemotherapy and you destroy their bone marrow for life. So now they don't have an immune system. And if you stop there, they would die, right? But before they die, you give them back the stem cells and pray to God that it takes. And you rebuild a new immune system. Now, when this has been studied, the more intense the conditioning regimen, the chemo, the better it works for MS. And it's a lot of people's belief, myself included, that the rigor of the chemo is what makes the person better for several years. The stem cells just make them not die. And so it's not prime time. And there's still a lot that needs to be done before it is prime time. At present, I like to use disease-modifying therapies to treat my patients. And if I feel that we need a really aggressive therapy, I like to remind everyone that alemtuzumab, Lemtrada, is very close to a stem cell transplant in its efficacy. It's FDA approved with a very clear safety profile. And I think that's a heck of a way to go. It's my opinion. Good question. Thank you.
Wow. I am so energized when you tell these answers, I'm like, they all must be energized too. We all must be like buzzing around from your.
Well, lies and flattery will get you everywhere, Deb.
Oh
Thank
my
you.
gosh, seriously, you are so amazing.
I see that Joe Siders is on. Hey, Joe, it's great to see you, my friend. I hope you're doing well, buddy.
Desiree is asking about brain volume. She says, does it start as soon as you get a diagnosis?
So Desiree, that's an outstanding question, and I would expect nothing less. So your body shrinks as you age, right? So I used to be 6 foot tall. Now I'm 5'6" because I'm a little older. I've shrunk over the years. That's a lie, but you do shrink as you age, right? And your skin becomes thinner as you age, right? These are, my hair becomes thinner as what the heck? So it turns out that after the age of 18, all human brains shrink on purpose. They're supposed to. About 0.2% or 1/5% a year. Now, that doesn't mean that if you live to be like, 100, you won't have a brain. It's just that each year your brain gets a little smaller. And that's not a bad thing. But in the setting of untreated multiple sclerosis, brain volume can get smaller faster, like up to 10 times faster than the general population. And brain volume loss occurs in MS as early as you can measure it. So actually, Desiree, you're right. The very earliest time that you measure MS, you can see brain volume loss if you use like fancy pants softwares that like calculated in the MRI machine. The good news is many of our medicines, particularly our newer medicines, All right. So the Mavenclads and the Ocrevises and the Limtradas, these newer medicines can do a really good job of slowing brain volume loss. And in fact, some of them can normalize brain volume. And so when we are assessing someone and we want them to live their very best life despite having MS, we want them to be NEDA 4, NEDA, no evidence of disease activity 4. What are the 4 things? No attacks, no new spots on MRI, no disability on exam. And then number 4 is normal brain volume. And measuring brain volume in clinical practice is a discussion point. I do it. There's softwares that are approved by the FDA. I use one called NeuroQuant. There's others, Iconmetrics, which is a fantastic one also. And these softwares are used in, they're not academic scanners. I use a really nice 3 Tesla Siemens Skyer machine, and it has this software. And so I can measure your brain volume when we get an MRI on that machine. And that allows us then to look at it and then make decisions accordingly. Great question.
Thank you. In the near future, do you think the prices of medicines for MS will get more affordable?
Ooh, that's a good question. I think it will, because I think we're going to have a bubble burst. Now, this is conjecture. Like, no economist has asked me this question, and no manufacturers calling Aaron for advice. I mean, so this is just my opinion. All right. MS medicines go up by double digits in price annually, which is insane. So I'll use copaxone as an example. Copaxone, which has been made by Teva Neuroscience for a long time, came out in the mid-90s and cost $8,000 a year. Today, copaxone is $98,000. It's gone up $90,000 in 20 years, and it's no different. It's exactly the same as it was 20 years ago. Every other medicine that's been out 20 years is free. It's like, pennies. It's only the MS space where each year they go up in the cost, and that's horrible, frankly. Now, there is some very early movement towards rectifying that weirdness. And I want to point out a manufacturer that I think did a really cool thing, and they don't get enough credit for it. There's a company called Genentech, and I like Genentech. I lecture for them. I mean, I do a lot of stuff with them. And when they made the medicine Ocrevus, they decided to set a flat price, and they didn't negotiate, and they didn't accept a kickback, and they didn't negotiate with anyone, and that was the price. And it's the cheapest MS medicine, even though it's the most used MS medicine in the world. It's the cheapest medicine of all the MS medicines. And I think that they could have done what everyone else did and just gone up and up and up, and they didn't. And I think that's really cool. When you think about like economics and you think about like economic crises in the United States, and like right now, I sort of feel like we're in like a housing crisis, and there's this bubble where prices are getting bigger and bigger, and we're fearful it'll pop and they'll all drop. And I kind of hope that that happens, and there's a day of reckoning with MS medicines, but nobody's called me about that day just yet. I will point out one thing real quick. There are ways of navigating to find tricks and tips. I'll give you one really quickly. And this is with a medicine that I like a lot called Aubagio. So Aubagio is a branded medicine, and if you have insurance, it can get paid for. And a lot of times my patients with insurance pay nothing, which is fantastic. But what do you do if you don't have access to insurance? There's a medicine called Arava, which is not approved for MS. It's an RA medicine, and it's really inexpensive, about $8 a month. And when you swallow it, the first metabolite is Aubagio. So when patients of mine have trouble accessing insurance or whatever, I can put them on that generic Arava. It works just as well as Aubagio. Now, am I suggesting that you take Arava over Aubagio? No. Am I suggesting that like generics are the answer? No. I'm simply saying the goal is to get treated, and we're going to do that any way we can. And we are typically pretty successful in trying to find ways. So thank you for that question.
Thank you. There's a
so
question.
This person, Karen, said it's not the cheapest medicine. And Karen, you're incorrect. The Ocrevus is priced at the WAC price, which is the price that they sell it at as the cheapest medicine. The amount you're paying is the markup from wherever it is you're getting it. So they're not passing that on to you.
Alpha lipoic acid, is it good for multiple sclerosis?
Yeah. So there's a lot of research about supplements and minerals and vitamins and things that may or may not help MS. And they're not studied as rigorously as MS medicines for several reasons. But there's a couple that rise to the surface as being useful. And alpha lipoic acid is super safe, and it has good evidence that it could help with progression of MS. And so I think that it's something worthwhile exploring. Now, do I think everyone on the call should jump on some alpha lipoic acid? No. Should you talk to your clinician before you do that? Yeah. Is it reasonable? Yeah, I think it's reasonable. Absolutely.
Okay, I have a question. So we only have a couple minutes, which means really about one question. Do you have just a couple minutes to go, or is the warden saying dinner's ready in 4 seconds?
Let's do 4 minutes so I don't have to spend the night in the naughty corner.
Okay.
We'll budget more time next time.
Absolutely. Okay. Let's try 2 questions if that's
Deal.
what it takes. Okay. So on average, do individuals have more negative reactions with Limtrada other than DMTs? Forgive me.
So Limtrada, in my opinion, is the most effective medicine I've ever used and the most complicated with the highest risk profile. Does it have more side effects? I mean, I think it depends on the individual. The list of things that could happen is pretty long. But I remind you that they're all treatable. So Limtrada side effects can be categorized in 4: infusion reactions, autoimmunity, because it can cause autoimmunity, particularly thyroid, and to a much lesser extent, kidney and your platelets. It can cause infection and a very low risk of cancer. So that's a lot of stuff. And it takes a very particular person who is interested in accepting upfront risk and complexity in exchange for the chance of having their disease get really boring down the line. And I would submit to you, having talked to thousands upon thousands of families with MS, that most people do not want to accept that exchange program, but some people do. And for those people, Limtrada tends to be a really great drug. Joe Siders said it really nice. Limtrada, go big or go home. That's right, brother. Go big or go home. That's right.
Thank you. Okay, our last question is going to be by Patrina, who said, as a person with MS, I have cerebellum ataxia. I've had this since August 2021. Will this ever go away? I recently started Ocrevus. I was on Tysabri for 4 years.
So the cerebellum is the little brain in the back of your head, and it's your guidance system. So if you think of your finger as like a missile and you want to shoot the missile right at the screen, your cerebellum guides the finger like guiding a missile. And if you're curious about what I mean, you can do an experiment at home with something called ethanol, or sometimes people call it alcohol, or people call it beer or vodka. And when you drink alcohol, it inhibits the cerebellum temporarily. So when someone slurs their speech because they've been drinking, that's because they turned off their cerebellum, and the cerebellum controls the cadence and coordination of your speech. Why does someone who's been drinking knock over their drink? Because their hand's ataxic, because their balance is no longer very good. And why do they stumble when they walk? Because the cerebellum's messed up. Well, nature can be too generous, and MS can cause damage to the cerebellum the same way alcohol does, except MS, it doesn't go away. And you share in your story that, this has been going on for a while, and it's been hard and it hasn't been getting better. And I would submit to you that cerebellar deficits, coordination deficits, are very hard to treat. And there's no medicine that I'm aware of to fix them. Like you take a medicine and the cerebellum gets better, but there is something to make it better: physical therapy. Now, I have a couple videos on my YouTube channel specifically on this topic, balance and multiple sclerosis. And the take home from those videos is that physical therapists can retrain your balance. They really can. There's a series of increasingly more challenging exercises that they can run you through and teach you. And you can teach an old dog new tricks, as the saying goes. You can do that. You can teach someone who has a cerebellar problem to improve their balance. And so I would suggest that you get ye to the physical therapist and get your balance on.
Thank you. Outstanding answers. So I'm going to say that unfortunately we can't get to every one of the questions. You had a huge number that we haven't gotten to, and I'm going to encourage everyone that's on here today to come next month. We're going to advertise the date. Actually, it's not next month, but the month after. Write down your question and ask it again, and be the first one in.
And we may be able to have some of the folks in your organization copy these, like record these questions, so we could even ask some of them next time.
Yes, that's a great idea. Great idea.
Well, I am so excited that I get to see you again in only 2 months. Thank you, everyone who took the time to take some moments out of your evening to up your game with MS. If you're not familiar with this organization, you need to be, because they are fantastic. I love working with you guys, Deb. Thank you very, very much. And you guys can find me on the interwebs. Check out my YouTube channel, Aaron Boster, MD. You can find me on Twitter and Facebook and Instagram, all that kind of stuff as well. And I'll see you in 2 short months.
You're out there. So that brings us to the end of our time. If you've missed any part of this conference, it has been recorded and it will be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access recordings, or sign up for our newsletter to learn about the upcoming events. Our next teleconference will be next Tuesday, July 12th at 3:30 p.m. Eastern. Dr. Ben Thrower will be presenting the topic of MS and vaccines, flu, shingles, pneumonia, and COVID-19. As you leave the conference today, a survey will appear on your screen. We ask that you please take just a moment to give us your feedback on this program today and your suggestions for future topics, so we can be sure to bring you the best programs possible that are most meaningful to you.
And if I can put I'm sorry, I just wanted to put a plug in for Dr. Thrower. Ben, who is a good friend of mine, is one of the most amazing MS educators that exists, and you're in for a treat. And I would like to learn from Dr. Thrower about vaccines. That's going to be a really, really great talk.
Yeah, it is. It is. Our sincere thanks to all of our attendees and for your participation, and especially to Dr. Boster for your willingness to share your time and your expertise and your speed at answering questions, your busy schedule, and taking that away from your family tonight. So, and for educating us. Good night, everybody, and we look forward to seeing you next time. Bye.
Take care, everyone. Have a great night. Bye-bye.